Our next speaker is going to be Dr. Doug Shook, and he's going to present aortic stenosis, no need to be afraid. Management of patients with aortic stenosis for non-cardiac cases. Dr. Shook is the Chief Division of Cardiac Anesthesia at the Brigham and Women's Hospital. He received a medical school education from Michigan State University. His research interests are anesthesiology, 3D imaging techniques, cardiac anesthesia, echo, perioperative medicine, and pain management. I will just add a personal note to his bio. He is the person that when I have a cardiac patient for non-cardiac surgery, I go to consult because I need sometimes the reassurance from a cardiac person. And then he always offers a free tea if I get into trouble.
Thank you for that. For that introduction, and it's really a privilege to be here. I'm so happy that we have people in the audience and so many people virtual that we can talk to, and I look forward to the questions that we have after we're done. So my topic is aortic stenosis. No need to be afraid. I mean, true, not true, we'll see how you feel at the end. I do have a couple disclosures. I do some education work for Edwards Life Sciences, mostly in the area of imaging. So my objective is to design a perioperative plan or pathway for patients for aortic stenosis who are undergoing non-cardiac surgery. We've got lots of sources. One thing I will have to say about aortic stenosis and how it goes, the definition seems clear, but actually it can be very complicated. And that's where a team approach, just like anything else, a team approach is critical. And we'll talk about that a little bit more as we move through. So what are the definitions of severe aortic stenosis? These are the classic definitions. If you go to the ACC, AHA, American Society of Echocardiography, what they'll say is if you look at an echo report and you see any one of these, doesn't have to be all three, just one of them, a high peak velocity of 4 meters per second, a mean gradient of over 40 millimeters of mercury, or a valve area of less than 1 centimeter squared, your patient has severe aortic stenosis. But you can imagine that these numbers don't all occur in that way at the same time. And in fact, if you do the math and work it out, if I have valve areas of 1, I may not have mean pressure gradients of 40. But it's just one goes forward. And I'll talk a little bit more on that as we move forward. What about moderate aortic stenosis? What are those? Well, just for an update, it's velocities of 3 to 4. A mean gradient of 25 to 40 and valve areas up to 0.5 centimeters squared. So what would you do with this patient? And I'm sure we've all had instances of this. You have a patient for a laparoscopic cholecystectomy, or at least is on the schedule. You look up your cases for tomorrow and you're like, okay, I got a lap chole. Sounds like a nice day. 70-year-old patient. But you come in to see them the next day and you hear a murmur. And so it's not plain, but it's a systolic murmur, right? So you're like, uh-oh. So I don't see any recent echoes or anything. What do I do with this? So you dig a little further, and it could be any one of these things, right? So some are worse than others. And then you do find an echo. Echo shows valve area of 0.9. A mean gradient of 25 and an EF of 55%. And the question is, do you need more information? What do you go for here? It's a laparoscopic cholecystectomy. What if I changed it to a knee arthroscopy, or let's say a liver resection? What's the plan for this patient? Should I be concerned? And just like I said, we've got one that falls in the severe and the mean gradient that falls in the moderate range. And that's not unusual. So here's the problem. Right, this is an echo of aortic stenosis. You can see the valve. I think this works. Oh, look at this right here. So you've got a valve here, an aortic valve that isn't opening, is calcified. So you can see that's a fixed obstruction. It's going to be hard for the blood to flow from the left atrium to the left ventricle and come out the aortic valve. Theoretically, not theoretically, the biggest problem with aortic stenosis is if the heart starts beating harder, the stroke volume doesn't necessarily go up to meet the demands of the person. So the problem is that, and we've reported the risk of complications can be quite high, and these are all complications. So up to 10, even 30% of cardiac complications related to this disorder in the perioperative period. So that kind of leads us to screen or fear or just a lot of concern. So where did this concern come from? All right, so these are some classic articles, some dating back to 1964 over here, all the way up to 2005. But if you look, interestingly, so we see complications. That's not an issue. 10%, 13% cardiac death, 55% greater or higher of MI. But the problem is when you go and look at the definitions, well, the ones in, 1964, we didn't have a whole lot of definitions. We had, patient has an aortic lesion, probable important aortic stenosis on the basis of clinical examination and catheterization in some, suspected critical stenosis with higher mean gradient on the basis of clinical examination in ECG, which is not a great way to differentiate severity of aortic stenosis. This one, the fourth one, has a peak gradient of greater than 40, okay. But a peak gradient of greater than 40 actually also is not severe, it's a mean gradient. And then, or definition of aortic stenosis by ICD-9 code, but again, probably not stratified as far as severity. Or how severe is it? So that's the problem. Now, what ends up being the critical piece when you see a patient with aortic stenosis, the first differentiating marker is, are they symptomatic, right? So do they have syncope? Do they have a history of heart failure? Do they, do they have, arrhythmias? Other things that make them symptomatic from the aortic stenosis. And if you actually only look at the asymptomatic crowd, the difference between patients with asymptomatic aortic stenosis and matched controls is actually not that different as far as overall outcome, 30-day mortality, and MI. So that asymptomatic piece is critical. I'm going to say that's the first differentiating point. Does the patient have symptoms? So if I show you this, and this comes from the heart guidelines, European heart guidelines in 2022, and we'll go through all of them. This says management of patient with severe aortic stenosis in need, here we go, for elective non-cardiac surgery. And the first question that comes up is, do they have symptoms? And if the answer is no, it takes you down a very different pathway, because if you have no, and the risk of the non-cardiac surgery is, say, low to moderate, then it may be okay just to proceed. Where if the risk of the surgery is higher, fluid shifts, blood loss, hemodynamic instability, then you may want to consider them for a valve replacement. But if they have symptoms, you automatically go to an area where, boy, they need valve replacement. And if they don't need valve replacement, we actually may consider doing nothing or having that team decision. So if you go to the ACAHA 2020 valve heart guidelines, their level of evidence is 2A, so that means it's reasonable. And it says that asymptomatic patients with moderate or greater degrees of aortic stenosis are normal LV systolic function. So here's a new one. Normal LV systolic function. It's reasonable to perform elective non-cardiac surgery. That's a pretty broad statement, actually. It doesn't even say what type of non-cardiac surgery that could be. That's pretty broad. I'd say it's a little bit too broad. And actually, they fixed it. So in 2024, the valve guidelines, they're just published last November. They gave, now these are not, these are not the valve ones. These are perioperative evaluation of patients, cardiac patients for non-cardiac surgery. Two different guidelines, both from similar sources. They very specifically said we've altered this a little bit based on what the valve guidelines were in 2020. So first is if you have a patient with severe aortic stenosis, they should be evaluated to see if they need an intervention prior to their elective case, which makes sense. And whenever it comes to valve intervention, typically is if the patient would have valve surgery without the surgery, they should get it, right? So maybe it was a diagnosis that came before, and before their elective non-cardiac surgery, they should have their valve intervened on. Two, If you have a patient with aortic stenosis who are undergoing elevated risk NCS, non-cardiac surgery, at the very least you should have an echocardiography, and I completely agree with that, before you proceed. And 3, which is the 2A, and this is where the difference occurs. In asymptomatic patients, so asymptomatic, moderate to severe ES, normal LV function, as assessed by echocardiography within the past year, it's reasonable to proceed with elective low-risk NCS. So they differentiated a little bit. They just didn't say anything. They said, well, if you're going to proceed, it should be low, and if it's higher risk, it's going to require more decision-making. So what's low risk? So I give this, not a strict definition. The real definition is what's high risk. High risk is blood loss, hemodynamic instability, massive big fluid shift type surgeries, okay? Those types of surgeries typically have a perioperative risk of morbidity, mortality greater than, or MACE, cardiac risk greater than 5%. Ones that are 1% or less are the ones you see under the low risk category, or examples, lumpectomy, thyroid, knee scope, colonoscopy, bronchoscopies, lap chole. Interesting, I picked that one. Elevated risk would be major abdominal surgery, major vascular surgery, things where you'd expect blood pressure and some hemodynamic instability. So people always say, well, what about balloon valvuloplasty? And although the most recent guidelines say it is, you can consider it, a lot of the research says it may not be that much very helpful. That if you actually look here at, I keep losing my pointer. Here we go. I mean, the two lines don't separate that far. So the balloon valvuloplasty doesn't really buy you a whole lot in the perioperative space. What can buy you a fair amount is TAVR. Now, TAVR has actually changed a lot of what we do, right? Isolated aortic valve replacements for most patients are now done percutaneously through the groin. We don't, just a single AVR, typically our younger people get surgical AVRs as the lone operation, tend to be younger because maybe we're going to put a mechanical valve in, or the other reason would be they have bicuspid valves. Or there's some other instance, there's something else that's complicating their journey where they may need more than just a single AVR, just AVR alone. And in that case, it's definitely better than balloon valvuloplasty and likely has an increased role in this patient population. So going back, I like the way these guidelines are written because it's very simple. So say we've got symptoms, yes. So we're going to go down the pathway of AVR before non-cardiac surgery, but when we say aortic valve replacement, now typically what we're talking about most of these patients is TAVR. And when we talk about TAVR, what we're saying, and the nice thing about that is if we're going to do that, their recovery and ability to move on to the surgery that they need will be much faster, rather opposed to the 2 to 3 or 4 month recovery needed after an open bypass surgical operation. Now, if you look at the green square at the top here, I also add one more thing to the guidelines that I think is important. It's management of severe ES and need elective non-cardiac surgery in patients with normal EFs. Okay? We're assuming normal EF when you're going down this pathway, and I think that's really important. If we actually look at the updated 2024 guidelines, if I follow that pathway I just showed you, if we go aortic stenosis, multidisciplinary team discussion, asymptomatic, normal ejection fraction, non-elevated risk surgery, that's where you get to here. We've just been talking basically about this little corner. If you have symptomatic patients, candidate for AVR, if it's yes, and when this is talking, you say, well, are they elevated risk for the AVR? Team-based discussion as to which way you go here, SAVR, which is surgical, or TAVR, or TAVI, which is the percutaneous route. And then let's go down this one route with the asymptomatic over here. Elevated risk, yes, so moderate or high-risk surgery. Can you delay it? No. And then it becomes a team-based approach as to how to best proceed. So if we go back to these guidelines, sorry. I keep hitting the back button. Okay. So this is an older paper, but I think it's a really good one. The valve heart guidelines are great. It's nice, concise. But this actually really explains, in my opinion, the decision making. If you're going to pick something to read, I'd read the new 2024 perioperative evaluation of cardiac patients is always a must read. That just came out. It's a must read. It's a must review. But to complement your knowledge of aortic stenosis, I think this is one of the best reads you can do. One of the things that comes up is it goes through the dogma of how gradients are created, why you get that dissidence between the different parameters, which I think is a little bit beyond the scope of this lecture. Know that there can be dissidence between the parameters. Know that you need only one to determine severity. But because of that dissidence, whatever parameter that ends up being, this is why you need the team-based discussion, because it may be more severe than you realize or less. But the key piece is, what are those things that make somebody with severe aortic stenosis even higher risk? And there's a couple things on here that I think are particularly helpful. So to label patients at increased risk for cardiac events during non-cardiac surgery with severe aortic stenosis are people with really high mean gradients, that means the valve's really small, or valve areas that are particularly low, less than 0.8. These are the big ones. If you've got LV systolic dysfunction, that's a problem. If the LV is already starting to decompensate for the chronic pressure overload of the ventricle, and it's starting to decompensate and it's less than 50%, these patients can be much more complicated to manage, and they can also decompensate much quicker on the table when you're anesthetizing them. Symptomatic AS, so anybody that's had syncope, anybody that's had, and we'll go through all these, but all the things that can come with aortic stenosis. This is the other one that doesn't always get brought up. But if you have significant associated valvular heart disease, so say the patient not only has severe AS, but has severe MR, that's even more problematic. Those patients, so LV, I'm going to add a couple things. So really high gradients, really low valve areas, LV dysfunction as a result of that, so EF less than 50%, or other significant lesions that can make managing the aortic stenosis much more complicated. So you can imagine if you have mitral regurgitation, which is causing blood to flow back into the left atrium, but you also have severe aortic stenosis, so you can't push the blood forward, it's all going backwards, and it's going to go backwards even more, and having the complicating factor of having an anesthetic that's going to reduce both your preload and your afterload, really, really prone to having complications. And where, for me, that's where I feel particularly at risk. And then the final one is significant coronary disease that's untreated. Keep hitting the back button. So what would you do? All right, so you've got a patient going for the lap chole, which we've already decided is in the reasonable risk category. A 70-year-old, murmur heard on exam, valve area, but considered severe, but mean gradients aren't high, but you have normal left ventricular function. All right? And if I didn't write it, let's assume the valves aren't a problem. The other valves aren't an issue either. So in this case, do we have signs and symptoms of aortic stenosis? So you ask the patient, do you have exertional dyspnea? Do you have decreased exercise tolerance over the past several months? Heart failure symptoms, and exertional angina, exertional syncope. All those things would make you symptomatic. That's symptomatic AS. Recent echo, so make sure that echo's within the past 12 months to help you evaluate. Evidence of coronary disease, right? That's one of the other big ones. And that reason for the recent echo is also to look at the other valves. Make sure the other valves are all, like, if at worst, mild MR, mild TR, things of that sort. And I would include, the other thing I would include, it's LV dysfunction that gets talked about, but if for some reason you had RV dysfunction, which there would most likely have to be other lesions. But if you had, I would say any type of ventricular dysfunction. If the RV is significantly dysfunctional, that would also concern me too. So in this case, our patient's asymptomatic, normal biventricular function, valve area is greater than 0.8, so not super small valve area. The mean gradients aren't incredibly high. We don't have other significant valvular issues, and no evidence of significant coronary disease. we're probably good to go. What are the key tenets of anesthetic management? So the critical piece here is I typically would try to keep MAPs above 70, mean arterial pressures, not systolics. I probably use that with phenylephrine. My induction will be sold and controlled, and I'm going to give you my cocktail. And I actually like, when I'm dealing with when patients who are critical, I like using shorter acting drugs, because if I don't like it, I want it to go away. So my anesthetic may be a little bit more expensive for this patient. And what we're trying to avoid is what I call the circle of doom, right? So you start with hypotension, you have a fixed obstruction that we saw in that echo, which starts producing ischemia. So now I've got hypotension, I can't increase my stroke volume, the pressure inside the heart in the LV is maintained, but the obstruction doesn't let me to produce more blood flow. So I get reduced contractility because of the ischemia, which produces more hypotension, which causes this circle that, unless you break it by increasing your blood pressure, you end up with, that's where you get the MI, arrhythmia, and death. So keep your MAPs up, and other than that, what other things do I think about? Well, in general, you don't want your patient to get incredibly tachycardic. So usually I manage that with pain control or my anesthetic. You can, if the patient has normal LV function, that gives you the ability to use a little bit of esmolol to try to slow the heart rate. I wouldn't use longer acting drugs because you don't want to reduce your contractility long term. Sinus is key. If your patient is in sinus rhythm and sinus rhythm, it doesn't end up being the case anymore, AF, most likely atrial fibrillation, these are patients that you can try to slow the heart rate, but I would cardiovert them. So I actually would have defibrillator pads on the patient. Be aggressive with treating hypovolemia. Avoid the circle of doom, which means use something. Use phenylephrine. Be aggressive with phenylephrine drips to keep the pressure, the mean pressure up. And contractility, you want to maintain at baseline, which primarily means avoiding ischemia and hypotension. So what about anesthesia for sedation? So what I would use would be standard monitors, adequate analgesia, a nerve block if you can do it, peripheral. I actually really like this. This is a cocktail. I like this sedation anesthetic that we've been using for TAVRs for the past 10 years. So all our TAVRs are done with sedation. And we developed this because it really has a minimal effect on SVR. And basically it's using remifentanil as your primary sedative, and I give you my dosing range, using propofol not for sedation, but actually for PONV, because Remi can actually cause people to get sick. And when they get sick, that's a hard thing to fix. But if you start with propofol for a minute or two at like 10 to 20 mics a minute, which is really not much, that's what prevents your PONV, antiemetic. And in the remifentanil, you start the remifentanil about 5 minutes later, and they're fine. And the beautiful thing is, it's from a SVR standpoint, these patients are pretty well sedated, but your SVR is not affected. And you've got nice pain control. And if you don't like it, you turn it off, it goes away, which is one of the things I really like in this patient population. What about general anesthetic? Standard monitors, defibrillator pads, arterial line. I would put an arterial line in all these patients pre-induction. And if this is one of those complicated patients where fluid loss is possible, blood loss, hemodynamic changes, all that, probably consider a central line, and more importantly, a TE if available. These would be your this is not my lap chole. We've decided this patient needs the operation and I can't get around the aortic stenosis. And then nerve blocks, anything that can help me not need as much anesthetic. So induction, etomidate is always a good choice, but if I'm gonna extubate something, I'm worried about nausea and vomiting, you actually can use propofol, and I'll talk to you about that in a moment. Phenylephrine drip, and then your opiate of choice, where I maintain with inhalational opiate, phenylephrine drip, and esmolol as needed to control heart rate in small doses. So here's my cocktail. I would personally use propofol in almost all these patients, but remember we just talked about what the amnestic dose is versus keeping somebody completely still. You only need amnestic doses. That's the part that's the part we get concerned about is we give enough propofol for amnesia, but the patient can still move, and everybody in the room gets concerned. Propofol, 1 milligram per kilogram of propofol in almost any patient, they're asleep. Especially if you give the fentanyl, if you have a remifentanil drip running behind. All these patients, I always run 40 mics a minute before I push the dose to just maintain SVR. Lidocaine IV push. And I don't wait in patients with aortic stenosis or any really sick patient. I push the neuromuscular blocking agent right after the propofol. I don't test to see if I can mask them. Propofol, blocker, 1-2. They're not going to remember. And the last thing you need, if you've already decided you're going to push that drug after you push propofol anyways, now that we have reversal agents and everything else, all you're doing is losing the time before you start to desaturate. And then maintenance, inhalational with remifentanil drip, phenylephrine drip, longer-acting narcotic if you need it. And I use the BIS, so you don't always have to use it, but I use the BIS because I don't want to over-anesthetize somebody and fight SVR when I don't need to. If it's somebody that doesn't need much anesthetic agent, I want to know. Neural axial anesthesia, typically avoided, but if you can titrate it slowly, I do it with an arterial line and keep your maps up. Post-operative, this is actually really important too. Depends on the procedure, where they go to the PACU or the ICU. But the key things here are, you want to make sure the person they still need to be monitored. So you want to make sure they don't get hypovolemic. And you want to make sure that whoever's taking care of the patient is cognizant of blood pressure. So if you've had no blood pressure issues throughout the case, you extubate, no blood pressure issues, maybe that's more of a PACU person, where if you've been fighting blood pressure the whole time, maybe ICU, it just depends. That's a team decision, and obviously good pain control. So in summary, always have to involve the heart team, but normal EF, no significant valve disease, minimal coronary artery disease are critical things when you're dealing with this patient population. And then it comes down symptoms or no symptoms. Symptoms, different pathway. You got to figure out if you need to change that valve. No symptoms, it moves you down a different pathway where if you're doing low-risk surgery, they're probably good to go. Where if it's a higher-risk surgery, again, do we need to replace the valve or do we need to take a more critical look at the numbers that we're using to come to that decision? My summary, keep the maps up, phenylephrine, slow and controlled induction, and again, when I'm dealing with this type of a sick patient population, shorter acting drugs, because I can take them away. My cocktails to manage heart rate, rhythm, preload, afterload, and contractility. Again, really good article. It's old, but just solid if you really want to understand the nuances of aortic stenosis. Valve heart, these guidelines just came out in November. Must read for anybody who's an anesthesiologist. Which includes the more complex pathway and the piece where it's reasonable to proceed with elective low-risk non-cardiac surgery. And I thank you very much for the time I got to spend with you.